continuación se va a impartir una conferencia nominativa Paul Angulo, de todos nosotros conocidos, y el doctor Eduardo Marín, que es un hepatólogo, amigo de la asociación, expresidente, con una carrera extensa en México y en Estados Unidos, amigo personal de Paul e impulsor de esta conferencia nominativa, nos va a hacer favor de presentar algunos detalles previos y posteriormente al doctor Sokol. Lado, si eres tan amable, por favor.
Muchas gracias, Rafael, y muchas gracias a la asociación por permitirme presentar al doctor Ronald Sokol. Rápidamente quisiera decirles que Paul Angulo, para muchos de ustedes, ya conocido, un gran médico, joven, falleció en el año 2015 en forma prematura. Paul Angulo fue un agente que trabajó originalmente en enfermedades colestásicas y enfermedades autoinmunes, especialmente colangitis biliar primaria y colangitis esclerosante primaria en la Clínica Mayo, y posteriormente trabajó en forma muy intensa en hígado graso no alcohólico, que fue el campo que desarrolló en la Clínica Mayo durante muchos años, y posteriormente se fue a la Universidad de Kentucky, donde terminó su carrera. Este es el artículo famoso en New England, que para la muerte de Paul tenía 2.245 citas, nada más. Por otro lado, este fue otro de los artículos impactantes en la historia natural de la enfermedad del hígado graso no alcohólico, publicado en Gastroenterology, con gran parte de sus fellows y con su mentor, que fue Kay Lindor. Este artículo tenía 1.043 citas para ese tiempo. Paul publicó cerca de 270 artículos indexados en PubMed y tenía gran relevancia. En los Estados Unidos, tanto Lupita García-Tsao como Maru Rinella iniciaron el proyecto de tener un premio, un Travel Award, como llaman la Asociación Americana de Enfermedades Hepáticas, en honor de Paul Angulo, y desde 2016 este premio ha estado ocurriendo. La conferencia nominativa Paul Angulo es ahora, a 3 años de su muerte, una realidad. La primera plática la ha presentado su mentor en la Clínica Mayo, nuestro amigo Kay Lindor. Él presentó el impacto de los estudios, del estudio de las enfermedades colestásicas y del hígado graso no alcohólico. Lo presentó en el año 2016 en Mazatlán. La segunda plática la presentó Anna May Deal. Presentó qué pasaba con NAFL en ese momento. Anna May Deal trabajó intensamente con Paul. De hecho, sus últimas publicaciones fueron con Ana en los Estados Unidos. Esta plática se presentó en Mérida, Yucatán, el año pasado, y este año, en el mismo tenor y con gran honor, es para mí un placer presentar al doctor Ronald Sokol. El doctor Ronald Sokol es el presidente de la Asociación Americana de Enfermedades Hepáticas, y es una gran distinción que el doctor Sokol presente esta conferencia llamada Hepatopatía asociada a falla intestinal. El doctor Sokol, como todos ustedes saben, ha estado aquí con nosotros, y él es un experto, es un pediatra muy distinguido, que verdaderamente tiene un currículum impresionante, que no es posible que ahora lo diga doctor Sokol completo, pero me parece que tiene un currículum sensacional, impresionante, y lo felicito a su corta edad, porque más o menos compartimos las mismas edades, así es de que me parece sensacional que tenga este currículum. El doctor Sokol es profesor de pediatría del Departamento de Pediatría y vice-chair de investigación clínica y translacional en el Departamento de Pediatría de la Escuela de Medicina y Hospital de Niños de la Universidad de Colorado. Es director e investigador principal del Instituto de Ciencias Clínicas y Translacionales de la misma universidad en Denver, perdón por el error. Es jefe de la sección de gastroenterología, hepatología y nutrición pediátrica, y actualmente él es el presidente de la Asociación Americana de Enfermedades Hepáticas en este 2018. El doctor Sokol ha recibido por 12 años consecutivos a través del NIH un grant muy importante para investigación, que pocas gentes lo logran en los Estados Unidos, Y el doctor Sokol ha sido una de las gentes que fueron de los primeros en describir la deficiencia de vitamina D en los enfermos con colestasis. No me da tiempo en presentar todo el currículum del doctor Sokol. Me da mucho gusto recibirlo en México y me da muchísimo gusto también decir que la Asociación Mexicana de Hepatología ayer anunció el premio Paul Angulo, que va a compartir tanto con la Asociación Americana de Hepatología como con la Asociación Mexicana de Hepatología para 2 jóvenes investigadores que puedan tener una estancia en los Estados Unidos muy bien pagada, tanto desde el espacio clínico como el espacio básico. Dr. Sokol, it's our pleasure to be here with us. Thank you so much.
You put this on widescreen. There you go. Well, thank you very much. It's really my honor to be presenting this lecture to all of you. This is where I live. Usually has sunshine. I understand that the sun usually shines in Cancun, but we haven't seen it all week. But it's really an honor again to present this presentation to you. Paul was really a wonderful investigator and really showed Americans all that Mexicans could bring to science in the United States. And I would like to state that the disease I'm going to talk about is a combination of just about everything that Paul studied. That is steatosis, cholestasis, fibrosis, predictive models of outcomes, and finally some of the complications of liver failure. Here's my disclosures, and none of my past consulting really is relevant to this presentation. So I'd like to quickly review the epidemiology of what's now called intestinal failure-associated liver disease, stress that there's different stages to it and that this is a chronic disease even when patients come off of parenteral nutrition, speak to the role of intravenous lipids, something we've called the gut lipid-liver axis, and then talk about modern approaches to prevent and now to treat this very important disease. So as all of you know, parenteral nutrition, intravenous nutrition, really is one of the major advances in the last century that allowed patients with severe intestinal problems and surgery and trauma to the bowel to survive. Unfortunately, an adverse effect of this rapidly became known, and most called it then parenteral nutrition related or parenteral nutrition associated liver disease, PNALD. More recently, it's become clear that the severe form of this disease almost exclusively occurs in patients who we say have intestinal failure. So it has now been labeled intestinal failure-associated liver disease, probably the same disease, and it is the single highest indication, the major indication for combined small bowel liver transplants or multivisceral transplants. Now, intestinal failure is the inability of the intestine to process and absorb nutrients to maintain adequate growth and development. In infants and children, the patients I see, intestinal failure is generally caused by short bowel syndrome, congenital neuromuscular disorders such as Hirschsprung's disease or pseudoobstruction, and a variety of congenital defects in enterocyte formation and transport, including a disease called microvillus inclusion disease. Now, in both adults and children, there's several phenotypes of this disease. One is a steatohepatitis. Then there's biliary tract disease, particularly related to gallstones, and finally cholestasis, which predominates in infants and young children. All of these forms, given time, will progress to cirrhosis, portal hypertension, and even patients with hepatocellular carcinoma have been described. We define parental nutrition-associated cholestasis as a direct hyperbilirubinemia, over 20% of the total in a baby who's been on parental nutrition more than 14 days and's had other liver diseases excluded. Now, the incidence of these diseases are now becoming well known. Premature infants will develop cholestasis when they receive parental nutrition. Almost 100% will after a few months of parental nutrition, but if they do not have intestinal disease, it's almost always reversible completely after the children start eating. It just depends on how premature they were at birth. However, those with gastrointestinal surgical diseases, that list I showed you, or short bowel syndrome, 20 to 30% of those infants will develop this progressive disease. And there's some very nice studies in adults that show even a higher proportion of adults develop it. And I'll show you some data here. This was a very nice study out of France where they looked at adults with what was called permanent intestinal failure, from infarctions, volvulus, radiation, Crohn's disease, etc. These patients had been on home parental nutrition for at least 45 months, and they assessed liver biopsies on 57 of these patients and quantitated fibrosis. They also defined a subset of patients who developed what they called complicated liver disease, and those were patients who had elevated bilirubin, variceal bleeds, ascites, portal hypertension, encephalopathy, or low factor V levels. And remarkably, what they showed was over time, there was a sequential increased proportion that were developing disease. This is the probability of being free of liver decompensation, either fibrosis or clinical biologic complications. And at 5 years, roughly half of the patients suffered from significant hepatic fibrosis. Very interestingly, and this was from the year 2000, this publication, they showed that those patients who received less than a gram per kilo per day of intravenous lipids had a much better survival free of liver complications than those who received over a gram per kilo per day of intravenous lipids. And typically, patients receive up to 3.5 grams per kilo per day. And they stated in their article that the parenteral lipid intake of a gram per kilo per day or more was a significant contributing factor to cholestasis, and they recommend giving no more than a gram per kilo per day. Now, when this was published, many of us thought that this was the result of needing parenteral nutrition, not the cause of the liver disease. But these authors actually were right back in the year of 2000. The significance of this disease can be seen in these infants with intestinal failure, and those with an elevated bilirubin above 2.5 compared to those with a bilirubin less than 2.5 out of 80 short bowel syndrome patients at Michigan had a increased risk, a relative risk of mortality of 22.7 just based on the bilirubin alone. This is about as high a relative risk, I think, as any of us have ever seen in a study, again, showing how important this liver disease is once it develops. The other interesting factor that's just come out recently was shown by this group from Helsinki, Finland. And in Finland, they are performing routine protocol liver biopsies in children with short bowel syndrome who are on parenteral nutrition. And even after they come off of the parenteral nutrition, they're performing routine liver biopsies. So here were 38 patients who had liver biopsies. 16 had a liver biopsy while they were still on parenteral nutrition for at least 74 months, so that's many, many years. And then they performed liver biopsies on 22 of them who had short bowel syndrome, who were weaned off of parenteral nutrition a median of 8.8 years previous after receiving 3 years of parental nutrition. And not surprisingly, 94% of those on parental nutrition had abnormal liver biopsies, but surprisingly, 77% of those off of parental nutrition had abnormal biopsies. And this just shows you here on the left that patients on parental nutrition had inflammation compared to those who were weaned off. Not a surprise. Cholestasis was more severe, those on parental nutrition than those weaned off. But the surprise was that the amount of fibrosis was not significantly different in those on parental nutrition compared to those weaned off with the red arrow, and the steatosis was virtually identical between the two groups. So we now view this liver disease as one that has different phases. There's a cholestasis inflammatory phase while the patients are on parental nutrition. When they're weaned off of parental nutrition, those resolve over a period of time, but the steatosis and fibrosis persist, and in some patients, as I'll show you, continues to progress. So there's probably two phases to this disease. One is the cholestatic phase. The second is a long-term fibrotic phase. Now, as in most of the liver diseases we've heard discussed at the meeting here, the microbiome clearly plays a role in this disease. As you know, with intestinal injury of any sort, you're increasing intestinal permeability, the intestinal barrier breaks down, and you absorb either intact bacteria or various bacterial products that can stimulate innate immunity in the liver. And we've heard a number of talks about non-alcoholic fatty liver disease in the microbiome and alcoholic liver disease. I would suggest this is the disease where there's no question the microbiome is involved. So for instance, here's a study where the fecal microbiome was examined in 3 groups of infants, again, age about 4.5 months. 7 had asymptomatic short bowel syndrome. That means their liver was normal. 14 had parental nutrition-associated liver disease, and 5 had multiple episodes of bacterial sepsis, CLABSIs, and had short bowel syndrome. And then they compared this to healthy infants. And I think it projects pretty well. On the bottom is the group with the parental nutrition-associated liver disease, and they had very different phyla and families of bacteria compared to the group above it, asymptomatic short bowel patients who did not have liver disease. Proteobacteria, which contain Enterobacteriaceae, were heavily overrepresented in that group. Again, speaking to the dysbiosis and the presence of bacteria that contain high levels of endotoxin. So, summary of the beginning of my talk is that intestinal failure-associated liver disease is actually common in patients with intestinal failure, both children and adults. It's the leading indication historically for intestinal and multivisceral transplants in children. It's a chronic liver disease even after the patient comes off of parental nutrition, and it appears that the intestinal microbiome is related. So the underlying question to really get a handle on this disease is what causes it? And there's been a variety of suggested components of the parenteral nutrition that may be toxic, or that there are a variety of potential nutritional deficiencies that the patient may have that could have led to this disease. And without going through this exhaustive list, let's just cut to the chase. And the most recent area of focus is the intravenous lipids, both the amount of lipid and the type of lipid that is being given. Now, this first became evident as a potential etiologic factor when in Boston, they had some infants with parental nutrition-associated liver disease who were allergic to soy oil, that's intralipid, so they were desperate to feed these children, and they put them on an experimental fish oil emulsion called Omegavin. And lo and behold, they were treating them now for nutrition, but lo and behold, over a period of a month or two, this one child's cholestasis resolved, and they were shocked, so they started treating other infants. And then they reported this open label trial in a number of infants who received fish oil after they developed cholestasis compared to another group that remained on 3 grams per kilo per day of intralipid. And what they showed is the group that received fish oil had a significant drop in bilirubin, while the soy lipid group had a continued rise in their direct bilirubin, and the same thing happened with ALT. This was very provocative, but these were historical controls. It wasn't a randomized trial. There was a lot of controversy over this study. So others realized that in that study, they used 1 gram per kilo per day of omegavin versus 3 grams per kilo per day of intralipid. What would happen if you just reduced the intralipid, the soy oil, to the same amount as the omegavin? And now there's been a variety of studies showing that if you take infants, again, who have intestinal failure-associated liver disease, and you drop the amount of lipids to 1 gram per kilo per day, that you can get the same reduction in their direct bilirubin, as you can see here, as if you switch them to the fish oil emulsion. So it seemed that it's the amount of lipid and not necessarily the fact that fish oil is different than intralipid. And there's a third lipid strategy, and that is to switch them to something called SMOF lipids. SMOF is a combination of soy oil, MCT oil, olive oil, and fish oil, and it was licensed in the United States for use in adults just last year. It's been used in Europe for a number of years. And here's a study where infants, again, with intestinal failure or cholestasis, were switched to SMOF and compared to a group who remained on intralipid. And here is the group that switched to SMOF. You can see over time, usually takes 2 to 3 months, their serum bilirubins fell. And this is compared to the intralipid controls where their bilirubins continued to rise. So once again, this is another lipid formulation at 2 grams per kilo per day that seemed to reverse the cholestasis. So how does this all fit together? Well, first of all, intralipid soy oil contains high amounts of omega-6 fatty acids. Omega-3 fatty acids predominate in fish oil lipids, and they are anti-inflammatory as opposed to pro-inflammatory omega-6. But we also see a difference here in the dose of lipids. Again, fish oil emulsions are never given at more than 1 gram per kilo per day. But perhaps there's something else that's toxic that's in these preparations that switching from soy oil to fish oil reduces, and the component of interest are called plant sterols or phytosterols, the equivalent of cholesterol in plants. And these have been shown in past years to be cholestatic in a variety of different models. They interfere with FXR signaling and bile salt export protein expression. Finally, there is clearly more vitamin E in the fish oil emulsion than in the soy lipids. So here's just some of the differences. Again, intralipids, 100% soy, omegavin, 100% fish, and SMOF lipids is basically an equal proportion of all of those. This shows you the essential fatty acid mixture, and again, the omega-6 fatty acids predominate in the intralipid, whereas omegavin has almost no omega-6s, linoleic and linoleic, but more EPA and DHA, and finally, SMOF lipid is right in between. This is the differences in plant sterols, and these are striking. Their phytosterols have a value of 400 milligrams per liter in intralipid, 3 in omegavin, and about 200 in SMOF lipids. And finally, the vitamin E differences, again, 38 milligrams per liter in intralipid, 150 to 300 in omegavin, and about half of that in SMOF lipids. So what's the horse here and what's the cart? Well, we tried to develop a mouse model to tease this apart, and before that, there are a number of factors that have been recognized as being associated with IFALD. And these include the ones in yellow that we're going to study, and that's the parental nutrition component, bacterial overgrowth in a dilated small bowel, sepsis and endotoxemia, and the component of intestinal failure, and many of these are dependent upon each other. So we developed a hypothesis that particularly in the infant who has immaturity of their bile salt pathways for synthesis and transport, that they have a propensity for cholestasis already, and the intestinal barrier function is altered in infants until they're about 6 months of age. So under those circumstances, if you injure the intestine and have bacterial overgrowth, dysbiosis, inflammation, abnormal permeability, and parental nutrition caused by the diseases there in blue, that this would lead to increased absorption of endotoxin or lipopolysaccharides, other molecular associated, microbial associated molecular patterns, and sepsis, that all of this would stimulate the Kupffer cells and the other macrophages in the liver to generate activated cells, leading to secretion of cytokines and reactive oxygen species, et cetera, and that this would lead to inflammation, hepatic injury, fibrosis, and the biliary cirrhosis that we're used to. Importantly, the parental nutrition lipids play a facilitatory role in this, that it is not just having the intestinal injury, but having the parental nutrition lipids, and we wanted to define the mechanism for that. So we developed a simple mouse model where we took adult mice, induced intestinal inflammation and increased permeability by feeding them DSS. This is dextran sulfate sodium that's commonly used to create inflammatory bowel disease models in mice. And after just a few days of that, we put a central line in, gave them parenteral nutrition, and between 7 and 28 days sacrificed the mice and looked at various factors that I'll just show you a sprinkling of the results. This shows their AST, ALT, bile acids, and bilirubin in their blood. And you can see that chow parental nutrition alone, normal saline through a central line, those mice had no significant elevations, but when we combined the when we combined the parenteral nutrition and intralipids with the treatment with DSS, we had a marked rise in all of these, and particularly the serum bile acids were anywhere from 4 to 10-fold elevated in those mice. When we switched them from intralipid to omegavin, we prevented this injury, very similar to what happens in humans. When we removed the lipid from the parental nutrition, we prevented the liver injury. And the red bar is very important. When we used omegavin and added the plant sterol stigmasterol, so we spiked the intralipid with stigmasterol, we replicated at least 70% of the injury based on blood tests. So this suggested that lowering the amount of lipid helps by the fact that we're lowering amount of plant sterol. Switching to omegavin is beneficial because we're eliminating plant sterols, and adding plant sterols back to omegavin replicates the injury. And without showing you a whole lot of data, I'll just summarize our experiments such that only when mice received total parental nutrition and had intestinal injury did they develop this cholestatic injury, that reducing the lipids, switching to omegavin, putting them on a cocktail of oral antibiotics to eradicate their intestinal bacterial flora, or using TLR4 mutant mice that don't respond to lipopolysaccharides, all of those protect against this injury. Moreover, when we gave plant sterols at plus the omegavin, again, it not only replicated the cholestasis, but it activated Kupffer cells in their liver and changed a variety of bile salt protein expressions. Finally, we've recently shown that it seems that IL-1 beta from hepatic macrophages seems to be the key pathway. Also TNF-alpha is involved, and NF-kappa B signaling within the hepatocyte carries this message from the macrophage that induces the cholestasis. So we've shown that there's a number of drugs already on the market: anakinra, which blocks IL-1 beta receptors, infliximab, which we all use in inflammatory bowel disease, and FXR agonists all seem to be protective in this model, which means there may be a variety of repurposed drugs that could potentially help patients that don't respond to lipid modification. And Are the plant sterols, is this just a figment of our imagination in mice? No, in humans, clearly the plant sterols in children on parenteral nutrition versus those that are weaned off of the parenteral nutrition, the plant sterols are very elevated in their blood, and the elevation in their blood correlates with the amount of inflammation in their liver, which parallels what I just showed you in our mice. So, how do we take this information and help manage these patients? Well, the first thing to do is to try to get them off of parenteral nutrition, because clearly the lipids and maybe other components can be hepatotoxic. So there's a variety of things that are done, including surgical procedures to lengthen the intestine, treating with cycles of oral antibiotics, preventing central line infections, using this new glucagon-like peptide analog called teduglutide, I just cannot pronounce that, teduglutide, Gatex, or human growth hormones actually been used in adults as a way to increase intestinal length and adaptation. And then finally, what we want to avoid is transplantation. So we have these three choices of lipids now: intralipid, omegavin, that's still investigational, but my understanding is it may be approved by the FDA, and then SMOF lipids. So the three strategies are to substitute omega-3 lipid emulsions, to substitute the mixed lipids, SMOF lipids, or to reduce the amount of soy lipids. So how do we try to put this into a clinical paradigm? Well, what we're doing now is, if we have PNAC with an elevated direct bilirubin in an infant with intestinal failure, is to either switch them to fish oil, omegavin, and if their bilirubin normalizes within 3 to 4 months, continue the fish oil, or one could switch back to soy lipids and follow them for a while. That would save a lot of money. Alternatively, reduce the soy lipids to 1 gram per kilo per day from 3 grams is the easiest thing to do, but then one needs to increase their glucose infusion. And if their bilirubin normalizes, stay there. If their direct bilirubin does not normalize, switch them to fish oil. Another alternative is to switch them right away to SMOF lipids, and if their bilirubin normalizes it, continue it. If the bilirubin stays elevated, change it to fish oil. And finally, another option is to change go right to SMOF lipids if they don't respond to changing the amount of soy lipids. So this seems to work in almost all patients. However, there's some cautions. And this has to do with the fact that switching to fish oil reduces the cholestasis and reduces the inflammation, but not only does it not reduce the fibrosis that we mentioned, there can be progression of fibrosis. So this is an infant who at 7 weeks of age had short bowel syndrome, had cholestasis, was switched from intralipid to omegavin, and here's sequential liver biopsies off of soy lipids showing progressive hepatic fibrosis, even though the child was no longer cholestatic. So this isn't something that we quite understand yet how this continues to happen, but it does happen. So again, that is one caution about using these paradigms. Another is the fact that brain growth in infants depends highly on the amount of lipid in their diet. That's one reason why breast milk is very high in lipid, to provide lipids for the infant's brain to grow. And here was a study where piglets were on parenteral nutrition, solely on parenteral nutrition, and they gave some of these piglets the normal dose of lipids, and then they reduced it in some of them. And the IL-5 is intralipid, 5 grams per kilo per day. The IL-10, 10 is the normal amount, is 10 grams per kilo per day. And the FO5 is fish oil, 5 grams per kilo per day. And then at 14 days, they sacrificed these piglets and weighed their brains as well as other testing. And you can see that the simple reduction in half of the amount of fat reduced the brain weight from normal to abnormal in these piglets. So there's a lot of concern that limiting the amount of lipids may not be healthy in the long term. There's also a more sophisticated study that was just published where a group looked at the amount of nutrition that preterm infants received and then did sequential MRI scans. Now this is enteral and parenteral nutrition, but there's a low energy group and a high energy group, 77 calories per kilo per day versus 93 in the high energy group, and head MRIs were performed 3 times at different gestational ages in both of these groups. And the point I wanted to make here is that the caloric intake and the lipid intake correlated with the size of the brain, with the amount of brain growth, the total cerebral volume in that third MRI. So those infants on lower amounts of lipid in their diet in this study had smaller brain volumes. And this complicated analysis showed that the lipids had the strongest correlation with the changes in brain size at each of these points. So we are a bit worried about the attitude of reducing intralipid to 1 gram per kilo per day or giving fish oil at 1 gram per kilo per day, that this might have long-term effects on brain growth in infants with intestinal failure. So in summary, I just wanted to again emphasize that we believe that phytosterols and intestinal microbiota are key factors that play important roles in the development of intestinal failure-associated liver disease, that reducing soy-based intravenous lipids when signs of cholestasis appear seems prudent until we have a better therapy. These alternative lipid emulsions may help. Again, SMOF lipids can be given at a full dose of lipids, whereas Omegavin is not advised to give it full dose of lipids. And long-term safety of these lipid modifications still needs to be determined. And now that we have some novel treatment targets, and that is IL-1, FXR, and macrophages, these might be alternative ways to treat this disease in children and in adults. So once again, I thank you for this honor in giving this presentation, and I hope you enjoyed it.